So for our first speaker, I'd like to invite Dr. Daniel Kastner, the Scientific Director of the NHGRI, Director, Division of Intramural Research and Head of Inflammatory Disease Section, and he's going to be our first presenter this morning.
Well, thank you very much, and it's really wonderful to be here. It's just such an honor to be here before you, all of the folks, both patients and families and other physicians interested in these diseases. Rafaela and Olche had asked me to talk a little bit about the revolution of genetics and genomics in defining immune dysregulation and the autoinflammatory diseases, from the monogenic to the polygenic diseases. So anyway, we'll do this all in 4 hours or so, something like that. So in any case, at least for me, to go back to the beginning of all this is actually going back almost 31 years now. And that is when I was a beginning rheumatology fellow, actually, at the NIH. And I saw the patient who's pictured here in the upper left-hand corner of the slide. At that time, I was seeing new patients in the rheumatology clinic, and we were referred this patient that had a lifelong history. He was 24 at the time, a lifelong history of unexplained fevers and usually monoarticular arthritis, that is to say arthritis affecting one of the joints at a time. And these episodes would last for a few days and then go away on their own, spontaneously, without any long-term sequelae in terms of any disability. And he'd have his joint aspirated at the time that he'd have one of these attacks of arthritis. And he'd have huge numbers of white blood cells in the fluid, in the joint fluid, as if he had an infection. But he didn't have an infection. No one could ever document that. And what we figured out that he had, and this was with the help of a fellow working in the same lab that I was working in from Israel, who pointed out to me that this was a simple, obvious case of familial Mediterranean fever, FMF. And what you're seeing here, perhaps not too legibly, but anyway, was the progress note. And that is what got me interested in this group of diseases. And at that time, the disease familial Mediterranean fever, it was known to be familial. It was known to be recessively inherited, but no one had any idea what the gene was or what the protein was or how that worked or whether there might be something that one could learn from that that would teach us something about the pathophysiology of human disease. So in any case, that got me interested in all of this, and this was in the context, so here's again our patients, this was in the context of some other things that were going on in science at the time. So pictured in the upper right-hand corner of the slide are 3 individuals that really had a profound intellectual impact on this whole enterprise. The first of them, Y.W. Kahn, was and still is at UCSF, and he was the first person to show that a variant in human DNA could be associated with the inheritance of disease. He did that actually for sickle cell disease. This was in 1978, and this was like an incredible breakthrough that in fact variants of DNA could be associated with the inheritance of disease. And it didn't take long then for David Botstein to come up with this idea that if a variant in DNA could be associated with inheritance of disease in a single family, then maybe we could make a map of the human genome that was based on variants in DNA that would be assigned to particular chromosomal regions. And he proposed that one could even map human disease genes doing this, and that one could find the genetic basis of human diseases. And then shown in the upper right is Francis Collins, who worked on finding the gene for cystic fibrosis back in the 1980s, and in fact was one of the people with Lap-Chi Choi that found the gene for cystic fibrosis in the late 1980s. So in the context of that, I thought, well, if those guys could find the gene for cystic fibrosis doing this, then why couldn't I find the gene for familial Mediterranean fever? And so, in fact, I set out to do just that. I took a field trip to Israel, shown here. This is a photograph of a family that I visited in Israel that has been modified basically to protect the confidentiality of the members of the family. But in any case, that field trip was in the summer of 1989. We were able to map Indian fever to chromosome 16 in 1992. And then it actually took us from then 5 years to figure out what the gene was. And that was because at that point, the Genome Project was just taking off. We were, in fact, the Genome Project for that part of chromosome 16, and so we had to develop all of the maps ourselves in order to figure out what that gene was. So that from the time that I saw that first patient to the time that we actually knew what the gene was 12 years. From 1985 to 1997. Now, not all of that were we working on it, but certainly the last 8 years of it, we were working very hard trying to find that gene. So in any case, that's sort of the way it was at the beginning. It took a long time. It took a lot of people. There were, in the final paper showing what the gene was, over 40 collaborators, a number of different labs on different continents that were involved in finding the gene. Subsequent to that, if we can now go forward to the other slide, those same techniques were then usable to identify other autoinflammatory diseases and the genes that cause them. And I'll just illustrate some of those. And this happened over the course of the subsequent 12 years or so, so from 1997 to 2009. So in the upper left is TRAPS. This is a laparoscopic view of the peritoneal cavity inside the abdominal cavity of a young girl, 7 years old, with TRAPS, who had recurrent episodes of abdominal pain, sterile inflammation of the abdominal cavity, and she developed adhesions, which you can see in this image. Here is hyper-IgD syndrome, which actually you've already heard about this morning, the gene for which was identified a couple of years after the gene for FMF, as was the case for TRAPS. NOMID, you've heard about as well. The genetic basis for that was discovered about 4 years after the identification of the gene for FMF. PAPA syndrome, pyogenic arthritis with pyoderma gangrenosum and acne. This is a very severe autoinflammatory disease where patients can have breakdown of the skin and the development of very deep inflammatory lesions. And then DIRA, a patient that Raffaella saw back several years ago, defining the gene for that disease at the NIH. So gradually, these techniques were taking off in terms of the length of time that it would take, 12 years for the first gene, and then here's 5 more that were found in the subsequent 12 years, and there were more, too, that were found over that interval of time. But then what really changed the picture in terms of finding genes for monogenic diseases was a change in the technique for DNA sequencing. And this was something that was basically promoted by and funded by the NHGRI, the National Human Genome Research Institute. And after the human genome had been sequenced, at least one human's sequence had been identified, and we had a reference sequence, then new techniques were developed for DNA sequencing. And this slide simply shows a comparison of Moore's law, which some of you may have heard of. That's basically the idea that the speed of computer processors and would increase by a factor of 2 every couple of years, and the cost would go down by a factor of 2 every couple of years. And then shown below it is the line with the boxes on it, which is the cost of DNA sequencing. And you can see that it paralleled Moore's law pretty well up until about 2007, and then the cost went way down relative to Moore's law. So that DNA sequencing became extremely inexpensive relative to computation anyway, and that's because of the so-called next-gen sequencing. And so with that in mind, it's really allowed us to solve unsolved cases much more quickly. Now at the NIH, we're reviewed every 4 years. And I just finished my quadrennial review about a week and a half ago. And so as part of that review process, I had said 4 years ago, this was in the wake of next-gen sequencing, and sort of just for fun, so that we'd have a goal to shoot for, that maybe we could find 10 new disease genes in the course of 4 years. Now remember that I'm the guy that spent 12 years trying to find the first of the genes that we were working on. So in any case, let me just tell you a little bit about that effort. So the first of the diseases that actually we've worked on is a disease in which children present with fever and early onset stroke. The first of the patients that we saw, actually we saw some 12 years ago, a young girl, 2 years old, referred to us from New Jersey, that had a lifelong history of recurrent fevers in her 2 years of life and had a catastrophic neurologic event, was referred to the NIH with the thought that she had NOMID, but she didn't have NOMID. What she had was multiple small strokes in the deep nuclei of the brain. And we didn't know what she had. We treated her empirically and have followed her ever since, but not really ever expecting that we'd figure out what it was. And then, about 3 years ago, we saw a patient from Texas, a 6-year-old girl, who had had 6 strokes over the course of her 6 years of life. And so we thought, well, gee, maybe there's some connection between these patients. And so what we'll do is to do next-gen sequencing on the 2 patients and their parents, 6 individuals altogether. And so in doing that, what actually we found was that there was one gene in common that could explain the fevers and strokes in those kids. And that's a gene that's called adenosine deaminase type 2, and this is just some figures from the paper that we published on this back in 2014, showing the skin rash that's characteristic of that disease, an MRI showing a stroke in one of the patients, and then a necrotic lesion of the ear in a patient that has a variant of this in which patients have vasculitis. Now, this was great, and it's the kind of thing that at least you can then understand what's going on, but of course, we had these kids with strokes to take care of too, and they continue to have strokes. It's not like it's just one stroke. So, and we now have a cohort of some 27 patients with this condition. So what to do? Based on some clues that we won't get into for lack of time, we thought that perhaps treating these patients with an inhibitor of TNF, tumor necrosis factor, might help them. And in fact, in 15 of these patients, you can see that their acute phase reactants did improve on TNF inhibitors. Before TNF inhibitors, this cohort of patients, 15 patients, had 55 strokes over 1,173 patient months of observation. That's about a stroke every 21 months. And then after starting TNF inhibitors, these same patients, we've followed for a total of 373 patient months of observation, and there have been 0 strokes on TNF inhibitors. So this is a case where knowing what it is and having some idea as to the pathophysiology actually can lead one to treatment. It doesn't always work out that way, but at least sometimes it does. Some of the other diseases that we've worked on over the last 4 years, some of you may not consider this a disease, vibratory urticaria. This is a condition where if you're toweling off in the morning or jogging, You can break out in hives. It's dominantly inherited, and it's caused by mutations in a new mechanosensor, which is on the surfaces of mast cells, which are some of the cells that lead to hives. This condition illustrated here, which we call HA20 for haploinsufficiency of A20, is a disease that looks kind of like Behçet's disease, where patients get oral ulcers and other problems, and it's caused by, we found, mutations in a gene TNF-AIP3. Another disease that has a similar pathophysiology, we just published 2 or 3 weeks ago, is a disease that we call otulopenia, because patients have too little otulin, which is an anti-inflammatory molecule that ordinarily would turn off inflammatory processes, but they lack this anti-inflammatory molecule, and so they get various types of inflammation, paniculitis, subcutaneous inflammation. With Raphaela, we were studying some patients that have Candle, a disease that Raphaela identified the gene for, and mutations associated with it. Some of the patients didn't have mutations in the gene that she had identified, but it actually encodes a protein in the proteasome, which is like a wastebasket in the cell that gets rid of proteins that shouldn't be around anymore. And it turns out that there are actually mutations in other genes encoding other proteins in the proteasome that are involved there. We saw a pediatrician from Philadelphia 2 or 3 years ago who had adult onset Muckle-Wells syndrome. That's supposed to happen in childhood. And it turned out that she has a somatic mutation in the same gene in myeloid cells. And then a couple of other diseases, a family from New York that has a combination of blistering skin lesions, ocular inflammation, pneumonitis, and colitis that have mutations in PLC gamma 2. And then children that have a syndrome of fevers, sideroblastic anemia, immunodeficiency and developmental delay that actually have mutations in an enzyme, in a gene that encodes a protein that modifies all tRNAs, one of the basic functions of all cells. So in any case, there's a lot that can be done now in the monogenic diseases with these advances in sequencing, and of course with functional studies that can be done subsequent to that. Just briefly, I will say that for genetically complex diseases, not all diseases are caused by a single gene, mutations in a single gene. There are common diseases in which there may be a combination of mutations, high penetrance mutations in a single gene, and then common variants that may have a lesser effect. And this graph just depicts the relationship between the frequency of a variant and its effect in terms of predisposing to disease. And so one of the diseases that we've been working on in that connection is Behçet's disease. This is a condition in which patients have oral ulcerations. They can have ocular inflammation. This is a patient in the middle who has pus in the anterior chamber of the eye, and then genital inflammation. And it's seen in populations, modern-day populations, that live along Marco Polo's ancient Silk Route, going from the Mediterranean to China and Japan and Korea. So in any case, it turns out that there are a number of genes that contribute to susceptibility there. A couple of them that are really interesting. One of them is HLA-B51, and this is work from Mike Umbrello, who's actually here at this meeting today, showing that in fact there are variants in the HLA-B51 molecule that are along the binding groove of this protein that may be involved in the binding of specific peptides, specific antigens to this molecule. And then interestingly, there are also variants, coding variants, in a protein called ERAP1, which is a protein that trims peptides and loads them on to class 1 MHC molecules. but it only works in people who are HLA-B51 positive. And as if that isn't neat enough, what is also the case is that these same coding variants are also protective for ankylosing spondylitis and psoriasis, but only in people that have the right HLA type for that. So it actually then connects Behçet's disease with these other two diseases in terms of their pathophysiology. So really neat things that one can find. And this is just a diagram of the various genes that have now been identified associated with Behçet's disease. I'll just finish up by saying that genetics and genomics put us in a place where we can ask interesting and important questions, but they're not the whole story. And if you don't have good biology, good functional studies going on that can follow after the genetic studies, then you've only gone part of the way. And so this is a diagram from a paper that we published recently having to do with the mechanism by which pyrin, the protein that's mutated in familial Mediterranean fever, works. Now you might say, what? You found that gene back in 1997, you're still working on that 19 years later? And the answer is yes, we are, and in fact it's taken us that long, we're slow, to figure out what actually is the mechanism by which pyrin works. And it turns out it's really neat, and this is partly inspired by some work by Feng Xiao in Beijing. So this is something where the whole world gets involved in it. And it turns out that certain bacterial toxins that can inactivate something called Rho-A, that's that thing up in the center, up at the top, toxins that inactivate Rho-A actually turn on the pyrin inflammasome. And what we've done is to figure out what's the pathway by which that happens. And it turns out that when you do that, you can understand then what's the mechanism by which FMF mutations work. You can figure out that there's actually a connection between FMF and HIDS, if you can believe that. And you can figure out the mechanism by which colchicine works in FMF, which is really neat too. And it turns out that there's actually this other disease that we didn't even know existed up until a few months ago that's caused by different mutations in pyrin that actually have another effect on this pathway, and it leads to a disease called POND, which stands for pyrin-associated autoinflammatory neutrophilic dermatosis, which is a very different condition relative to FMF. The other thing that's really neat that some of you may say, well, this is beyond the pale, but I'm going to say it anyway. We've always wondered why it is that so many people in Mediterranean populations are carriers for FMF. And it turns out that like 1 in 3 to 1 in 5 people in Mediterranean populations are carriers for FMF mutations. So why is that? You'd think that somehow or other it must be that there's some protection that's conferred by being a carrier for FMF genes for particular bacterial infections. And what I had shown you on that previous slide with regard to the bacterial toxins, well, the toxins that have been found were like botulism toxin, which nobody is going to say that botulism, has been selecting for a high frequency of FMF mutations. But what it turns out is that actually there's another organism, Yersinia pestis. Some of you may have heard of it. It causes the bubonic plague. And actually the toxins of Yersinia pestis not only can trigger the pyrin inflammasome, but there's another toxin in the plague that turns it off. And the studies that we're doing right now with a group up in New York seem to show that, in fact, carrier mutations, we're doing this with knock-in mice, not with FMF patients, that carrier mutations for FMF actually are protective against Yersinia pestis, which is really neat. And that may explain, why it is that there's the high carrier frequency. So in any case, there's a lot of exciting stuff to do, whether it's talking about discovering new single gene disorders, whether it's developing treatments that target those pathways, whether it's understanding the complex diseases where multiple genes are interacting, or understanding the pathophysiology. So it's really an exciting time to be doing this work. It's really an exciting time to be alive as a medical researcher. So anyway, I'll just end by showing you some photos of the folks in the lab that have contributed to all of this, and of course my colleagues at the NIH, clinical colleagues who have worked on this, and this is just the NIH Clinical Center where we've done a lot of this work. So anyway, thanks a lot for your attention.
Thank you, Dr. Kastner. Next, I'd like to invite up to the podium Dr. Stephen Holland, the Scientific Director of the NIAID, Chief Immunopathogenesis Section, Laboratory of Clinical Infectious Diseases, who will be presenting lessons learned from studying immunodeficiencies.
Thank you very much. It really is quite a remarkable experience to be here. I have to say I've mostly been here as a patient in the past and have always had profound respect for the organization. But hearing Commander Reed and Ms. Wilson and Ms. Durant, it really reminds me that we are one government, one team, one goal, which between the NIH and Walter Reed is to make awfully sure that we do the best thing for each patient each day. And I don't want there to be any ambiguity about that. I don't care about the gates and the guards and the problems. And we have them on our side. They're not as fancy and they don't have the guns. But, you know, we are one team with one mission. And please don't let anything stand in our way about that. So, you know, you get a bunch of old guys up here talking, and they spend a lot of time talking about the past. And I'm going to talk about it too. Now, Dan started in the beginning. I'm not going to start quite there. But I want to point out that the world population has been growing for a long time. And you can see that it's been going up in really quite a steep escalation. And it's hard looking at the curve of population to say, okay, where is it that antibiotics had their main effect? Now, almost invariably, and I will not embarrass anyone here, when you ask, what was the first antibiotic? People almost universally get it wrong. They say, oh, penicillin or something like that. No, the first antibiotic was discovered only about a century ago. And although they were looking for something to treat African sleeping sickness so that colonization could be pushed further into Africa, it turned out that it was effective at treating that other sleeping sickness called syphilis. But, or at least, you know what I mean. So, and then it was a little while after that that people identified the next antibiotic, Prontosil. And I mention it here in particular because I suspect this story is not as well studied here, and I know it's not studied across the street, but it's really a story that begins, and this book, which I get no profit from, I want to be clear, I have nothing to do with except to say I've read it and it's spectacular, starts out on the battlefields of World War I, wondering how is it that we stop surgical infections, battlefield infections, from taking lives. And it goes through that, through the development of the sulfa drugs, which were the first real agents to be useful in the early 1900s. So the take-home message I want to leave you with at the beginning is that human population's been growing for a long time, and antibiotics are really pretty recent. That must mean, for me as an infectious disease person, for Dan talking about Yersinia, that must mean that host defense is actually pretty darn good. So I'm just going to give as an example of that the fact that tuberculosis currently is thought to infect 1/3 of the world's population. Despite that, there are only a few million cases of disease each year. And I don't mean to minimize the importance of the disease, but it's a very small slice compared to those at risk. And the number that die is smaller still. That suggests that there must be critical host factors that are involved, because this is true regardless of antibiotic exposure. So this guy attended my last lecture. This guy was a priest in Egypt 3,000 years ago, and he died. And he died, you might wonder why, but you can see actually why he died, because here in his spine is evidence for an infection by tuberculosis. Now, this is the bovine, the cow-carried form of tuberculosis, but you can see where his spine was degenerated, and it collapsed, and it made his back kick out into that little thing called a gibbous deformity. And in fact, it dissected all the way down through the muscles along his spine, and we have proof of that because I was able to get this CT scan under HIPAA regulations. That the hieroglyph for HIPAA is very complex, I want to tell you. But this priest from Egypt died with what was just like this, an abscess that formed from tuberculosis and went down through his muscles along his spine. So the real question is, here was a guy who had every advantage 3,000 years ago, and yet he got sick and died. And what we really want to know is why. And that's the fundamental question. That's what we are always asking. Why this patient? Why now? Why here? And I have to say to those of you who are families, having been on both sides of the divide, most doctors are not eager to be stupid. They may think they work hard at it, but they don't. They don't mean to be ignorant. But rare problems, unusual problems, we call them rare for a reason. And figuring out why is what we are here to do. We exist to push back the walls of darkness, and that takes time and effort, and there is a lot of pain at that leading edge. So I'm going to walk you through one story. You know, to tell the story about immunodeficiency, there are 350 immunodeficiencies, and I only have 200 of them teed up. But I'm only going to work on one of them for today, and that's what this little boy had. So 1994 is when we started with this, and it was well into 2012 when we figured it out, reminding you that NIH also can stand for not in a hurry. So he came to me at age 6, desperately ill. You can see that his liver and his spleen were enormous. And the bone marrow example here, all that red dot, every one of those is a bacteria that was not being killed by his cells. These are mycobacteria. This was Mycobacterium avium complex, an environmental organism all of us ingest every day. Very few of us get sick with. And in 1994, what we knew about that was really precious little. We knew that IL-12 was made in response to ingesting mycobacteria. It had a receptor. That receptor turned on the production of interferon gamma, which then stimulated cells and led to killing of mycobacteria by a pathway usually known as magic. And that was about where we were in 1994. And we knew that if you gave people interferon, you could stimulate that pathway. Sort of makes sense. And so we did all those things that sort of made sense, and it didn't work. It didn't work as well as it was supposed to at all. And a couple of years into his treatment, his spleen got so big and his white blood cell count got so low that we had to take out his spleen. And despite all the right antibiotics and all the right drugs, you can see that his spleen was chock full of abscesses, all of which were full of mycobacteria. And so as he got older, things got no better. And he required his splenectomy, survived that, but then his medications got discontinued for a variety of reasons that we're all familiar with, and he developed sepsis, and he died. And we had no idea why. So now, fast forward about 2 decades, and another little boy comes in now, and you can see he's got massive lymph nodes here in his neck, a very large liver, and a very large spleen with lots of lymphadenopathy in his abdomen. And his biopsies, again, are chock full of bacteria. This is just a straight smear taken from a lymph node. You can see this macrophage so full of mycobacteria that it has burst. And here on both the acid-fast stain and something called an auramine rhodomine, simply too numerous to count. But now it's 2014. Don't we know more? Yes. Does it help us? No, not yet. Not until we come up to what Dan was talking about at the end. So by 2014, we've got lots more genes involved in our pathway, lots more opportunities to look for lesions, and yet we're still limited in trying to get there. Again, we try interferon gamma. Again, it doesn't work for him. And this boy actually wound up with a bone marrow transplant, which helped to clear his infection. So now we move on, because the theme gets more complicated. And that's the story of immunodeficiency. That's the story that I think, in part, Dan was telling you. They were very lucky that they found 2 kids who had strokes and fevers, and they turned out to have the same thing. But part of the backstory is that there are lots of kids who have fevers, and there are lots of kids who get infections, and they don't all have the same thing. And we only find the gene when we make the right guesses. So the next patient is now an older woman. And at 42, she comes to us with persistent bacteremia. She had tuberculosis that was cured at age 4. She developed lupus at 19. And when she came to us in 2013, she had had 2 years of large lymph nodes with persistent Burkholderia vietnamensis bacteremia. And this was the patient who, when we went in to talk to her, she says, "But wait, I've never been to Vietnam." And that turned out to be true. But she had this profound, you can see the lymphadenopathy, large liver, huge spleen, lots of lymph nodes, persistent bacteremia over years. And when we finally started to evaluate her, we took a biopsy of her intestine because she had persistent gastrointestinal bleeding. And you can see here just extraordinary, extensive ulceration all along the bowel border. And when I went down to the pathologist, he said, "Wait a minute, what is going on here?" Because here in the stain, it's a special stain called a Warthin-Starry stain of that part of her bowel, every black dot is a bacteria. Now we're not talking about mycobacteria, we're talking about gram-negative rods. All of that in a woman who was walking, talking, and taking care of her child, all of that is Burkholderia vietnamensis. And so he called up and he said, "I think you've got a Burkholderia storage disease," which obviously was true, but not a diagnosis. Finally, I'm almost done here. So I'm trying to give you the spectrum of complexity, because as we learn more about immunodeficiency, we also learn more about our own ignorance. This boy came to me from South Carolina with 4 years of persistent infection and persistent bacteremia with Bartonella hinzii. Now, Bartonella hinzii is something that takes a little time to learn how to pronounce and very complicated to remember, but he's got here colitis. You can see all of this involvement in his bowel, both small and large, with extensive proctitis here, and he had Candida esophagitis. And then finally, this boy who was referred in just last year with, you can see this large abscess. At 13, he had developed lymph nodes with coccidioidomycosis. And at 19, while trying to get into the Marines, he had trouble because he had this problem here in his groin. And when that was excised, it was chock full of coccidioidomycosis, now a fungus. So we've gone from a mycobacteria to a gram-negative rod, to another gram-negative rod, to a fungus. And finally, the little girl that is in our hospital right now, because we do have an inpatient service where we take care of these patients, a 6-year-old referred from Peru who's got disseminated BCG, that is the vaccine that's given to prevent tuberculosis, spent 4 years in the hospital in Lima before eventually being referred up to us. So the problem here is how to figure out what people have. And the modern way to do that, and frankly, it doesn't make any sense to do it the old-fashioned way anymore. The modern way to do it is using genome-wide studies and whole exome sequencing and whole genome sequencing that Dan and his institute have really pioneered, and you heard an extraordinary story about how powerful that is and what you can find doing that. In our case, what we found is that every one of these patients, stretching all the way back to 1994, had a single unifying problem. They had a mutation in the IL-12 receptor beta-1 chain that led to impaired signaling through IL-12, so it can't turn on interferon gamma production, and therefore they don't signal properly through their receptor. And although this was described in 1998, it was described around bad mycobacterial disease. And when we studied these children functionally, they looked like they were intact. But 1998, it was identified, and in most of those cases, they said you can give interferon gamma because that receptor is intact, but when we did that, it didn't work for our patients. So I won't bore you with all the details about this disease, except that it's got lots of manifestations, and it is characterized by infections with other gram-negative rods, other mycobacteria, as well as some other organisms like Nocardia and Klebsiella. And now we can add to those lists Bartonella, Coccidioides, and Burkholderia. So this receptor is important because not only does the IL-12 receptor beta-1 chain mediate signaling through IL-12, it also happens to partner with the receptor for IL-23, so it signals things that turn on both interferon gamma and IL-17. And now we know that it's associated with a variety of different infections, and most of these are things that like to live, at least at one point in their life cycle, inside cells. The final point here is that this disease, despite the fact that it shows up either in childhood or in adulthood, is still associated with a very high mortality. And so for those people who have Salmonella or BCG, things are not so bad. But the overall survival by the time people get into adulthood is low, suggesting that we need much better approaches to its management and treatment. So, what did we learn from all that? That Mendelian susceptibility to mycobacterial disease, MSMD genes, are not very mycobacteria specific, despite what you might hear. That the onset and type of disease in the United States is very different from that in Peru or Africa or Europe, and there's a lot of variability in this pathway in terms of infection susceptibility, therapy response, and outcome. So what are the take-homes from this? The most important take-home, and I think it unifies many of the themes here today, is that ignorance is transient. Despite how often you encounter it, we all actually fight against it. Knowledge endures, and once you have it, there is no stopping. Don't settle for effects. Don't settle for saying, well, this kid's got fever. No, fever is a symptom. You need a cause. Mycobacterial infection is a symptom. We need the cause. And as I think you heard very movingly from Commander Reed and Ms. Durant and Ms. Wilson, persistence pays off. Persistence in finding diagnoses and pursuing diagnoses, and then pursuing people who know how to get the job done. If there's anything I've learned about Walter Reed, that is what this place is all about. So I'd like to just acknowledge the people that did the work I've shown you here today in my own laboratory and in many of the collaborating laboratories around the world. Thank you very much.
Thank you, Dr. Holland. So now I'd like to introduce Dr. Raffaella Golbach-Monsti, who's the Acting Chief of Translational Autoinflammatory Diseases in the Laboratory of Clinical Infections, and she will be our final presenter for this morning's first morning sessions.
Thank you all, and I think we've had some good introductions to autoinflammatory diseases by the mothers who've been actually presenting their stories, and by Dan Kastner, who's been giving an overview, and who came up with the imaginative and visionary term autoinflammatory diseases after only having discovered 2 of them. And in fact, it turns out there are many more that actually present with fever, sterile inflammation, organ inflammation caused by innate immune cells, mainly neutrophils and macrophages. Untreated disease causes organ damage. I want to point out on 4 severe early onset diseases that are sporadic and not familial. that the mortality of untreated diseases in childhood is high. Patients have organ manifestations like short stature. They can develop blindness, they can develop hearing loss, they can develop hydrocephalus, meningitis, brain atrophy, cognitive impairment from untreated inflammation. Others, interstitial lung disease, that is the cause of death in a disease called SAVI in many patients, or basal ganglion calcifications. These are serious diseases. We start with a patient. We try to get them targeted therapies. My charge is to translate the findings that we make on the basis of the genetic studies, the immunophenotyping studies, the clinical phenotyping studies, and the modeling of their mutations in the lab into a treatment that works. There are a number of dysregulated cytokines that I will talk about later, where drugs are available for targeting. There are others that we can't target yet. If we get it right, treating these patients has a tremendous impact on their inflammatory phenotype, on their survival, and on their well-being, and I think you've heard that from the mothers. My journey started with this patient. He was actually referred in 2000 to the pediatric clinic that was started with Dr. Carol Barron in NIAMS, and this was the very first patient. And he was sent to us with the mandate to find treatment for him. And I took that serious. I was kind of at the beginning of my career, and a fairly established pediatric rheumatologist sent him to us, to me, to find out what was wrong. And that actually has been the mandate for the rest of my career with treating with these patients. We had to do research in order to do better. There was nothing out there in the literature that would help us to treat this patient. He had aseptic meningitis, which caused headaches, papilledema, increased intracranial pressure. He had an urticaria-like rash, and he had joint deformities. At the time when we saw him, Hal Hoffman had actually done linkage analysis on patients who also had neutrophilic urticaria, a familial disease, mild or cold-induced. Our group being young, we decided let's try and see if in that sporadic case that gene actually might have a role, and in fact it did. He had a de novo mutation, which at that point was found by luck in that gene that Hal Hoffman published to cause a familial disease. This was an intracellular sensor that in basic research labs was linked to activating an enzyme, caspase-1, which basically, when activated, cleaved an inactive form of a very potent fever-causing inflammatory cytokine into its active component, IL-1. It raised the question whether blocking IL-1, something that had never been done in these diseases, could actually benefit this patient, and led to the development of a clinical study in 2003. That's a study into Mr. Rand's son was enrolled as well. The benefits of treating those patients became obvious within 24 hours. Children who had rashes since birth started to have no rashes. The organ inflammation, including the aseptic meningitis, disappeared. The inner ear inflammation that was the cause of hearing loss disappeared. We later found out that long-term treatment led to continued suppression of their diseases. And with the help of the parents advocating for the children, and Sobi, the company that at that time distributed the drug, we were able to get this treatment approved for the treatment of NOMID. There are two other long-acting agents, canakinumab, another IL-1 blocking agent, and rilonacept, that were approved for the milder conditions of the disease in 2008 and 2009. The benefit of blocking IL-1 in the cryopyrinopathies has led to their use empirically in other fever syndromes, including DIRA, a patient who was in the ICU for 7 months, got started on this treatment because the physician thought that this patient had similarities to NOMID, and the child was discharged from the ICU within 2 weeks. Genetic analysis with Dan's lab identified that this patient had loss of function mutation in the very molecule we were giving him. He lacked endogenous IL-1 receptor antagonist, which we were giving him with the drug anakinra. So this pointed to the fact that uncontrolled IL-1 not only causes the disease manifestations in NOMED, but in DIRA, and became a paradigm for other diseases that we later found not to respond to IL-1 inhibition. This drug was also used in a disease that looks similar to DIRA and in the periodic fever syndromes, including FMF, that then Kerstner told you about. And it's beneficial. And I won't go into pathways and genes that regulate IL-1, but there are a number of those that regulate IL-1. All lead to amplification effects on causing organ damage in these diseases. And recently, work that was done with John Canner, who is actually in the audience and who's taken this ANOSYS research project, identified mutations in another sensor that is regulating IL-1 and IL-18. We've come a long way. We could treat the red-marked diseases with IL-1 inhibition. For 2 of those diseases, we have FDA-approved diseases. There are many others with other colors than red that are non-responding to IL-1 inhibition. The ones that are not gray, we have some clue to the cytokine loop that causes them. The ones in gray are more murky, and we don't have a single agent or a single inflammatory marker that causes them. Access to non-FDA-approved drugs for many of the patients who suffer those diseases is still a struggle, as the insurances, even when we have published data that the drug works, are still refusing to actually reimburse these drugs. This has been a burden for all of us working with patients at the NIH. I will actually tell you 2 examples where the genetic discovery and the pathogenetic evaluations have helped to identify other pathways that drive inflammation. I'll tell you about patients who have fever since birth, panicolitis, they lose fat, they develop metabolic syndrome, they have myositis and arthritis. Then told you about that we've been working on the discovery with 2 other groups on identifying that proteasome loss of function mutations in various proteasome components actually cause the disease. But it didn't help us treat these patients. So we did functional studies, including gene expression studies, and the markers on the red indicated that these patients, compared to the NOMED and CAPS patients, had a persistent interferon signature, suggesting that interferon was persistently released in those patients, which basically triggered a treatment. And this is a challenge because at the time when we wanted to treat a patient who was actually admitted for bone marrow transplant with CANDLE, there was no approved drug that would target the type 1 interferon pathways, but there were some in treatment studies. And it took a lot of searching. And it took one person at the company who finally made the decision of making a drug, baricitinib, a JAK inhibitor that would inhibit interferon signaling, similar to an IL-1 inhibitor that inhibited IL-1 signaling, to make this drug available in a compassionate use program, which has been very beneficial to those patients, but taught us also that we needed to pay attention to dosing and to side effects of new drugs in new diseases. Preliminary data suggested to expand the study. We developed an interferon score that actually showed us that this drug, in fact, inhibits interferon signaling and is associated with making those patients better. This disease finally told us that type 1 interferon dysregulation leads or is indeed a pathway that causes a number of these sterile inflammatory syndromes. Patient with vasculitis and interstitial lung disease. Many of those patients have tissue loss because of gangrene formation of their aqueous surfaces, the rashes in cold exposed areas. using whole exome sequencing and the trio approach, which, as Dr. Kastner showed, is actually allowing us to look for de novo mutations by filtering out rare variants that the patient has against their parents. So we can actually identify new variants only present in the patient and not in the parent to look for de novo, possibly disease-causing mutation. That's an approach we used. And this patient, in fact, had a de novo mutation in a gene called TMEM, which encodes STING. STING is actually known as an important regulator of viral immunity. And it actually leads, when activated, to the transcription of interferon beta, which in fact gave us genetic proof that chronic interferon production is causing inflammatory phenotypes. And it also suggested that these patients would benefit from blockade of interferon, and these patients, we were allowed to actually expand the compassionate use to those patients. This is a complicated slide, but it actually is telling us that there are now a number of genetic mutations that are associated with causing too much type 1 interferon production and various phenotypes, including Aicardi-Gouttiere, where patients get mainly seen by neurologists. They have neuroinflammation, early demyelinating disease, and end up being developing spastic quadriplegia and profound neurologic abnormalities. But in essence, it is actually an autoinflammatory disease where too much interferon exposure to an early brain leads to demyelinating disease. This is a patient with SAVI, with a STING mutation that Dr. Forsberg helped us. She had chronic infested vasculitic ulcers. The crusts you are seeing have been there for 3 years and not healing. She healed on the JAK inhibitor, but she had an ulcer in the top of her foot that didn't heal. And Dr. Forsberg helped us developing a treatment plan. The patient had a resection of some of the bone fragments that were left and a skin graft, and 2 weeks ago she sent us this picture, or this actually little movie that I'm not going to show you. She can actually walk for the first time. So this has made a huge difference to her life. This is a disease that Dr. Scott Kenner is studying, where gain-of-function mutations in another IL-1 activating inflammasome predispose to the development of macrophage activation syndrome, a sepsis-like state with a mortality of 30% if untreated, and you have heard about the severity of macrophage activation syndrome. In fact, by comparing patients with these diseases with the cryopyrinopathies, it turns out that their level of IL-18 is significantly higher than in NOMID patients and CAPS patients who are not at risk for developing macrophage activation syndrome. And Scott is looking into the meaning of high persistent IL-18 levels of predisposing to macrophage activation syndrome, a possible marker for other kinds of sepsis, particularly those that are associated with dropping cell counts, which is a marker, and high ferritin levels, which is a marker for macrophage activation syndrome in those patients. So what are the challenges? We have incredible opportunities to work together. We can identify molecular targets, but we need to work with pharma industry to actually allow a rapid access to some of the treatments that would actually target the identified pathway. Obtaining suitable drug access is a struggle. We need to develop appropriate treatment programs, and the challenges for an autoinflammatory disease network are marked out there. As you have heard, access to whole exome sequencing should be part of a diagnostic workup for any child with an early onset autoinflammatory disease who does not have any of the known mutations to cause the disease. We need to make this access possible. We need to enable somatic mutation screening. We need to be able to share and match phenotypes of patients who actually have undiagnosed or yet uncharacterized diseases. Immunophenotyping. We need to standardize our immune workup. We'll be discussing that in the sessions at the end. We need to develop treatment guidelines. There is a huge difference in knowledge about how to treat those diseases and diagnose them. And in the clinical trials network, we hope to actually implement clinical studies more efficiently and communicate outcomes. That actually brings a whole slur of obstacles that need to be targeted in order to make something like that possible, but we want to see if we can actually seed such an effort. And last but not least, what does this have to do with the military? Are some of these dysregulatory pathways that we identified in rare diseases relevant in conditions of military relevance, such as sepsis, bad vaccine reactions, and impaired wound healing? I think there is room for collaborations on that. This is the lab team, the clinical team, and the NIAMS support groups that have helped over the last several years with this project, particularly the clinical work. Dr. Montallegro, who actually is in charge of the compassionate use program, and Dr. DeJesus and Bernadette, who've been working on genetic and functional analysis in the lab. And Dr. Kenna, who's actually on his way to an independent work group to actually study macrophage activation syndrome. If we work together, there are lots of people that are needed in order to characterize and phenotype these patients with autoinflammatory diseases. And we hope to expand that network of support between Walter Reed and the NIH. So this is a very exciting time. And there are many who make this possible. I want to thank all the patients and families who have come numerous times to the NIH, and the companies that actually have provided us with drugs and support to treat those patients. Thank you.